Good morning, everybody. I want to introduce our topic this morning in our speaker group. Thank you for this opportunity to share with you the work that our DEI committee has been doing to optimize contraceptive counseling in the community. Today, we're going to be sharing with you information with a framework of reproductive justice, person-centered care, and cultural humility. And I also want to introduce, I'm Katherine Sampene, part of the ASOG division here at UW. And then I'm going to let you guys say hi yourselves, but this is the rest of our speaker group for this morning. So I'm going to let them stand up so people online can see too.
Most of you know me. I'm Berghahn. I'm in private practice with Associated Physicians.
Hi, I'm Jacquelyn Adams with maternal fetal medicine.
Okay. So just want to share with you all the outline for this morning to start off. We're going to introduce the project and then review person-centered care, cultural humility, and reproductive justice. We're going to review the problems identified and pose interventions. We'll then take a break before moving into discussing how people learn, case-based scenarios, and finally, next steps for the future. We're going to have some interactive portions of the talk today. So please feel free to speak up, particularly if you're in the audience here today. And then using the chat is great if you are virtual. We do not have any relevant disclosures. Today, we also recognize that pregnant people may not identify as female. And so we are making every effort to use inclusive language as we discuss our topics this morning. I want to also acknowledge all the people and groups that have helped on this project. From the DEI committee, Heidi Brown, who is now in San Diego, was a very crucial member. She helped with engaging with the community and she offered her expertise in implementation science. Cheryl Casey Grant is our outreach specialist and has been a big part of our community engagement as well. Jackie Askins has been helping with the communication as well as organizing, and Rob Garza created our patient-facing materials. Additionally, we had many members of the DEI committee contributing. Anastasia Doherty was going to be part of our speaker group this morning, but unfortunately is out sick. So we are sad that she can't join us this morning, but want to recognize her as well. And then as we all popped up on the screens earlier, Dr. Berghahn from Associated Physicians, Dr. Adams, one of our MFM doctors, and myself will be the co-presenters for the morning. We held a variety of listening sessions that included doula groups, including Roots for Change and Harambe Village, and then a wide variety of other folks. I don't know that I can point at the slide, but I know this is a little bit of a busy slide, so you don't have to worry about trying to read every small text. But we also engaged significantly with Meritor lactation and nursing representatives from all the practice groups at Meritor via the Pregnancy and Childbirth Care Committee, the Meritor Patient and Family Advisory Council, the Reproductive Justice Steering Group, and additional community input from attendees of the Chair's Advisory Committee, including the ConnectRx community health workers. We also appreciated input from Drs. Higgins and Swan, who do research on these topics and are part of CORE. We also sought reviews from Gender Services and UW Patient and Family Education. Going through this process took us about 2 years to complete. I want to acknowledge each contributor this morning in gratitude of the robust discussions and feedback we received. I'll also point out that various groups met with us at different points throughout the project, and we appreciate that despite all the work that's been done thus far, we'll likely have ongoing work and improvements even after today. Additionally, today's audience may be broader than our traditional grand rounds, as the invitation was extended to all of the groups and individuals that helped throughout the project. We ultimately identified 5 granular themes that we aim to improve as outlined here. Number 1, some patients do not like being asked repetitively about contraception and have a sense of being badgered. Some patients do not like being asked about contraception in triage or in labor. Some people, especially Black patients, are being targeted to choose LARC options in a way that is excessive or coerced. Some patients receive different counseling in the community regarding how contraception can affect breastfeeding, which can lead to mixed messages, confusion, and poor patient experiences. And some patients experience difficulty in getting LARC removed due to a provider encouraging them to keep the method or refusing to remove it. Of course, LARC removal does not specifically relate to pregnancy or the postpartum period. However, we decided to include it in our session due to the importance of the topic in our community. We learned about problems on the last slide from a wide variety of resources and sources. Our own patients have given us feedback directly as well as via patient relations. We held listening sessions where we received feedback from community groups. We also have published data, some of which comes from our own researchers at CORE here at UW. In the 1970s, the WHO advocated that patients should participate in their healthcare. Patient-centered care explores reasons for the visit, seeks a holistic understanding of the patient's world, finds common ground about the question and management, enhances health prevention, and a continuing relationship between the patient and the provider. It brings into view the biopsychosocial models. It benefits from enabling the patient, increasing patient satisfaction, reduction of system burden, and improvement on health outcomes. So person rather than patient-centered care focuses on the unique qualities that make people different from all other species. Moving from just the patient, which may be defined as one who suffers, to a person. Rather than just a sick patient, it identifies a person who may have an illness. It puts the person first. Person-centered tends to focus on the meaningful life, while patient-centered focuses on a functional life. While there is a great deal of overlap in the concepts of patient versus person-centered care, the terminology of person allows us to center the holistic human. On the right side of the screen is the ACOG committee statement number 1, and it is titled Patient-Centered Contraceptive Counseling. While person-centered language may be ideal, ACOG uses the term patient-centered. Terminology aside, ACOG clearly lays out a foundation for contraceptive counseling in their summary of recommendations and conclusions. ACOG states that we must acknowledge the historical and ongoing reproductive mistreatment of people of color and other marginalized individuals whose reproductive desires have been devalued. Bias affects care, and we must work to minimize this. We are called to prioritize patients' values, preferences, and lived experiences when counseling regarding contraception. We are advised to use shared decision-making. This next article outlines a much broader background to the topic of providing person-centered care in an equitable contraceptive care from the broader standpoint of policymakers, implementers, and researchers. It lays out the complex interplay on the left-hand side among the historical, social, political, and economic contexts, policy and health systems, and the community and family. Across the bottom, you see the continuum of care. You see outreach and trust, the importance of good access to care, the quality of care, and the follow-up support. In this huge interplay of important factors today, we are mainly focusing on the quality, which is the orange heading third from the left up there. This shows you the broader view of important contributing factors and that we are kind of, if you will, only biting off a real small portion of the work today. Many of us are familiar with terminology of cultural competence. It's the more traditional notion and terminology in clinical training that one can master a finite body of knowledge. Cultural humility is proposed as a more suitable goal in multicultural medical education. Cultural humility incorporates a lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to developing mutually beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and populations. Cultural humility focuses on really a lifelong kind of endeavor rather than a finite curriculum that's to be completed or checked off. The reproductive justice movement is based on 3 core values: the right to have a child, the right not to have a child, and the right to parent a child or children in safe and healthy environments. Loretta Ross, the co-founder and national coordinator of the Sister Song Women of Color Reproductive Justice Collective from the years 2005 to 2012, defines reproductive justice as a framework created by activist women of color to address how race, gender, class, ability, nationality, and sexuality intersect. Reproductive justice recognizes intersectionality, which is a concept that was introduced by Kimberly Crenshaw in the late 1980s, as various identities can layer to promote advantage or disadvantage. Layers of disadvantaged identities can lead to compounding barriers to access and reproductive injustice. It is a movement that is broader than pro-choice or pro-life, but takes into account justice in economics, social systems, race, education, accessibility, reproduction and sexuality, among other entities. Now we're going to start to touch on each of the topics that we identified in our project. We'll first look at the top item, that some patients do not like being asked repetitively about contraception and have a sense of being badgered. So why would badgering happen? Well, the reasons are likely multi-pronged. First, in this department, as in many practice models today, we operate really with a shared care model. Models where one provider sees the patient every single visit and delivers that patient is much less common today. In the single provider model, the provider is likely to recall what they discussed at prior visits, and they also know how they document in the medical record. When we use a shared care model, patients may feel they are repeating themselves, particularly if the documentation is not seamless. Additionally, providers may not be accepting of the answer the patient provides. For example, if the patient states that they plan to use a method with low efficacy, or they don't plan to use a method at all, the provider may feel compelled to revisit the discussion, particularly if the provider does not think that conceiving again or conceiving in a short interval is a good idea. So that moves us to the topic of bias. All people have biases, nobody is completely unbiased. But that being said, recognizing where your biases lie is really important. At the top of the slide there, you can see a list of examples that some providers may find difficult, such as teens, Medicaid status, race, marital status, substance use, and there's likely many other examples. You may have additional topics that you can think of where you personally find it difficult. Self-awareness will allow you to think about why you have a certain bias and to mitigate bias. So when you guys are seeing a patient in the clinic, are you able to recognize when a decision makes you feel kind of uncomfortable? Maybe you find yourself wanting the patient to really make a particular decision. If so, would anybody here feel comfortable sharing if they have maybe some of those other things in mind that are challenging for them, or reflections on that?
Hi, I'm Jenny Karnowski. I definitely caught myself thinking that, like, if I'm seeing a patient who's having like their 4th or 5th C-section, in my brain, I'll be like, well, why aren't you getting a tubal at the same time? And kind of assuming that that's going to happen. So like high parity or multiple C-sections has definitely been a bias of mine.
Yeah, and it doesn't mean that we don't counsel people about the risk of the 5th or the 6th C-section or something like that, but also recognizing the bias of you're like, let's get that tubal done, right? Yeah. Anyone else have a scenario or situation or idea they want to share this morning? And that's okay. Other things that, there are lots of other things that I think probably many of us do think about. Jamie, if you see anything in the chat, feel free to. No, okay, thanks. One might be BMI, for example, patient's weight. There's probably a lot of other ones out there that others may have in mind. But do remember, we all are going to have our biases. We aren't going to make those go away. But if you can recognize what's making you feel uncomfortable, what's making you want to push the patient in a certain way, you can catch yourself, you can mitigate that, you can make sure that your counseling is comprehensive and person-centered. And that's really the goal, is to be person-centered. The provider's role at the bedside is really to understand the patient's reproductive goals and wishes, and then provide that counseling accordingly. The provider should put into context the patient's unique health concerns, discuss optimizing birth spacing, and discuss the options. So back to badgering. Sometimes it may relate to the shared care model. Sometimes it relates to providers not accepting patients' answers. With a shared care model, we can think about some standardization to minimize the chances of badgering. In your practice, whatever your workflow might be, the important thing is that providers who share the patient, including our resident doctors, know where to find the information that was already discussed. For my practice, I'm suggesting that we discuss the contraceptive topic at the 28-week visit and then document that in the problem list. Of course, there's going to be nuances for the individual patients. If your patient wants to discuss that before 28 weeks, by all means, you should feel empowered to do so. But again, document that in the problem list. Additionally, be careful to accept and respect the patient's answer. That being said, patients always deserve accurate information, including information about optimal birth spacing and the risk of short interval pregnancies. Document in the problem list if and when the patient would like to be approached again about contraception if unsure. So this probably qualifies as a busy slide, but should look pretty familiar to the ASOG division and other folks. I think most practice groups have a very similar template that they use in EPIC in their practices under the pregnancy problem. And it's basically an outline of items they're planning to touch on during the pregnancy. You'll see at the bottom, there is a postpartum planning section, which includes a line item for plan for contraception. This is where it would be best to document that plan, and it may be as simple as something like progesterone-only pills. You might also want to write something like unsure, see note 7/1/2023, readdress at the postpartum visit. Something like that would go a long way to help the next provider seeing the patient. They know it's been discussed and they can reference that note if they wish. They also can see at a glance that the patient and the provider had a conversation and made a plan to readdress at the postpartum visit. It can remove the responsibility from the next provider to readdress during pregnancy, which otherwise may result in a sense of badgering. The next problem we identified is that some patients do not like being asked about contraception when in labor or in triage. So when do we need to ask patients about birth control and triage? It's understandable that patients don't want to discuss it when they're in active labor. That being said, it remains important to confirm the plans for post-placental IUD and tubal sterilization so that the team is prepared and the consents are confirmed. We definitely want to make sure that we're continuing to meet patient needs about their contraception, and this is required for these procedures. For all other methods that are documented in the problem list, it really isn't necessary to discuss them in triage. For hospital-placed Nexplanon or the shot, the brand of which is Depo-Provera, the discussion to confirm this can wait until postpartum day 1. The plan can still be put in the H&P with the plan to confirm postpartum. When contraception was not discussed in clinic, consider phrasing the question such that the reason that you're asking in triage is more apparent. You could say something like, I wasn't able to see in your chart that you discussed contraception in clinic. For most methods, it would be fine to talk about this after the birth, unless you wanted an IUD right after the placenta, or you were thinking about a tubal sterilization. These are the 2 options that are important for the team to know about before your birth. Did you want to talk about these options, or would you like to touch base after the birth? We don't want to throw the baby out with the bathwater, if you will. We want to provide excellent contraceptive access and services while we are optimizing our counseling. Keeping these points in mind should allow us for that balance. The next topic is that some people, especially Black patients, are being targeted to choose LARC options in a way that is excessive or coerced. And I should have probably fully written that out. There may be folks that are less used to the lingo, but LARC is a long-acting reversible contraception and refers to the arm implant, brand name Nexplanon, or the shot, which is the brand name Depo-Provera. This article was published by a local research team. You may recognize some of the authors, Carly Zeal, Jenny Higgins, and Shauna Newton. I know you're able to read these, but I think that the quotes and the summary of the article were quite profound. So I'm going to take the liberty to read to you anyhow. So I feel like you're maybe trying to tell me something, that you don't think that I'm responsible enough, or that you don't think I tried hard enough. Jessica. It seems like young African-American women are more pressured to use IUDs or implants. From my point of view, just from different things I've heard or different experiences. Although it seems like most adolescents these days, but I think more so it seems like African-American ones are pressured more. Amanda. I think it matters too, if you have a doctor that you didn't feel like you had a good relationship with, then I probably would be more like, well, nah, because they're not going to listen to me. Versus if I feel like I had a pretty good relationship with my doctor, I think that makes a big difference too. Amanda. I don't know if it makes providers look bad if you have an IUD removed and they're the one who placed it. Or I don't know if providers have some kind of stat chart somewhere, like a contest board in the break room. Katie, it wasn't me. But, the summary of the article was that women reported increased autonomy in relation to contraceptive decision-making when working in a cooperative relationship with their provider, and decreased autonomy if that relationship was dysfunctional. In a shared care model, it may feel difficult at times to develop the cooperative and functional relationship. However, striving for that relationship first will likely improve both the patient and the provider experience. In a good patient-provider relationship, the patient comes to know that you care about them as a person, the foundation of person-centered care. The quotes also remind us to check our biases. Are you as a provider unduly pressuring Black patients or any patients to choose LARC options? Examine that thought. And if so, why is that? Go back to the basics: person-centered care, cultural humility, reproductive justice. Spend time understanding the patient's wishes and priorities, a topic that we'll delve into in the second half of the talk today. Next, we will consider that some patients receive different counseling in the community regarding how contraception can affect breastfeeding, which leads to mixed messages, confusion, and poor patient experiences. And you're going to get a quick break from me while Dr. Adams presents to you this topic.
Hi, everyone. I'm Jackie Adams, one of the maternal fetal medicine folks. I think it's always good when we're doing a talk about bias to openly admit mine in the beginning. It seems more honest that way. And so I take care of high-risk patients, and therefore I will openly admit that my bias will always be managing health conditions, especially chronic health conditions, optimal pregnancies, spacing. And that's sort of just how I've always approached the topic of contraception. So being a part of this project has really been important to me to really look at my own biases and do I counsel people in different ways? And if a patient makes me uncomfortable in the very beginning, do I take that into my interactions? And so I don't know, maybe that helps if I just say it right in the beginning that that's where I'm coming from. But so I really tried to look at this talk from that framework and kind of start from there and figure out how I can work better to better counsel patients in a person-centered way. So I think we have all experienced that counseling about contraception and lactation can be a difficult topic because we have two extremely important public health priorities: the importance of human milk feeding and also the importance of optimal pregnancy spacing and preventing unplanned pregnancies. So the mixed messages patients receive often center around this controversy. The second phase of lactogenesis is triggered by a drop in progesterone after birth. Therefore, the theory behind contraception inhibiting milk supply is largely related to early initiation of progestogens or progestogen agents before milk supply is established. Not unique to our obstetric practices or our hospital, the very worthy public health efforts of increasing breastfeeding rates. And I do also want to say for this talk, most of the articles reference breastfeeding. So I'll use breastfeeding and chest feeding, but just knowing again that not all patients identify as female. Increasing breastfeeding rates and decreasing unplanned and undesired pregnancies may at times seem at odds. Of course, increasing breastfeeding and decreasing undesired pregnancies are not mutually exclusive public health efforts. In reality, depending on your background, training, and profession, you may admit that you have a bias that favors one over the other. As an MFM, I have sort of a different vantage point than maybe someone that's counseling the patient on lactation in the hospital. I have the benefit of knowing that patient and their congenital heart disease or their chronic kidney disease or their poorly controlled diabetes from the first time I met them. I've also had that time to sort of think about what's best for them in their future pregnancies. Whereas in that moment, that patient's number one priority is the baby that they see in front of them and making sure that they have an adequate milk supply. And I want to make sure that we're all addressing both of those important things. Today, let's dig into the data, and I will propose to you that both knowing the existing data and exercising person-centered care are necessary to work through this controversy and in fact make them make sense. It's also important that our patients understand that there's restricted access in our state to termination services should an undesired pregnancy occur, and that we have to keep this in mind as far as health consequences and adverse pregnancy outcomes when it comes to close interval pregnancies and having access to optimal contraception. This next paper, I think, should be required reading for everyone, especially this was actually the first time I had a chance to read it preparing for this talk. It's by Allison Stubbe, who's my MFM hero that someday I'll work up the courage to talk to at SMFM. And it outlines why public health efforts such as increasing breastfeeding rates and decreasing unplanned and undesired pregnancy rates have influenced bedside counseling. If you haven't heard of the term bedside advocacy, as it was new to me in this, it's when those, while we have great public health goals, espousing public health goals without person-centered care may adversely affect the patient experience. And this happens when advocates on both sides are speaking to the patient at the bedside and working on their own agenda rather than working in a patient-centered way to provide accurate information. Now, I don't think any of us do this on purpose, just to get that out in the open. I think we each come to the bedside with our knowledge and our experience and our background and our own experience with the patient, and it's impossible not to bring those things into the conversation. Just to summarize this really in a way, the article summarizes this in a way better than I think I could. And so I really just want to read the first paragraph to you. This was a clinical scenario, excuse me, that someone experienced, and they actually texted the attending physician that day to summarize. And afterwards, I want to take a few minutes for us to sort of reflect on this. At our institution, a 15-year-old Gravida 2 para 0111 had a spontaneous vaginal delivery of an extremely preterm infant. On her day of discharge from the hospital, a lactation consultant entered her room just as an OBGYN resident was eliciting her consent for a contraceptive implant. The lactation consultant asked a medical student in the room with the resident whether breastfeeding had been discussed. Once prompted, the resident advised the patient of a possibility that the implant can impact her milk supply. The patient decided not to have the implant placed at that time. One author received a text from the attending obstetrician later that day that read, "I just talked to one of the lactation consultants who advises women that immediate postpartum contraception, in this case Nexplanon, may decrease milk supply. I'm not aware of any literature to support this." This was a 15-year-old on her second pregnancy who just delivered a 25-weeker. Obviously, I'm all for breastfeeding, but I feel like presenting her something that is based on experience is not really neutral and fair, especially in such a high-risk teen when the literature on immediate postpartum contraception is so compelling. So I just want you to think about this a little bit. How does this make you feel? Have you had a similar experience? And sort of what are your immediate thoughts on hearing this clinical scenario? Anyone feel comfortable sharing?
It brings out one of the biases that I didn't mention earlier, and which is the teen pregnancy, and I think it just really highlights that, because I think it's a bias that many of us have, and it's clearly displayed in that scenario.
I think for me as an MFM, the thing I immediately jumps out at me is I could see myself having these same thoughts and feelings, because this patient had a 25-weeker, and my number one priority is thinking, I always say as an MFM, I'm not thinking about right now, I'm thinking about your next pregnancy. And in this case, maybe that's not person-centered. We need to talk to this patient about what her goals are, and her priority at this point is probably her 25-weeker that she wants to provide milk for in the NICU. And so how do we feel about the interaction, as far as it seemed like both sides were sort of hesitant about the information being provided? And I think that's what is really interesting about this interaction. How could they have made it go better? Yes. I was hoping someone would say that. Oh, sorry, for those online, we had an audience member say maybe just not having the conversation at the bedside, right? So I think this is a very literal representation of bedside advocacy, right? So I think that this would have been a really appropriate thing to step out in the hallway and talk about and say, what do we know? What do we know for sure? What's controversial? What are the patient's priorities? And then go in and have a conversation with the patient about their priorities and what they think. And so that was sort of the first thing that jumped out at me as well. Anybody else? So again, just take some time to sort of sit with that scenario and think about, how that makes you feel, how you would have handled a similar situation, or maybe how you have handled situations like this in the past. So speaking of controversy, there are a few things in this topic that we think are less controversial or not controversial. There's a general consensus that non-hormonal options such as sterilization, the Paragard IUD, condoms, diaphragm, and spermicide do not alter the milk supply. On the flip side, there's also a general consensus after, over 70 years of data that estrogen may reduce the milk supply in some patients. This includes combined oral contraceptives, the vaginal ring, and patch. I don't have a ton about the newer forms of progesterone only contraceptive options, including SLIN and O-pill. So far, there's a lack of data. And even the data on progesterone only pills is rather old, with the first study actually being published in 1976 and only of 20 patients. And from our general literature search, there's not a ton about the milk supply following that. There's also, at this point, no published data on drospirenone or nogestrel, though SLIN does say in the packaging that it can be given immediately postpartum. So while data is very limited, our work across providers and community groups indicates that this is a widely accepted by both medical providers and the community, progesterone-only pills. Unlike other controversial methods, if an individual was concerned about milk supply, the method is in their control. It does not require a visit to remove it or significant time to wear off, such as the injection. The major concern is the possibility of missing pills. And I will also admit my own postpartum bias of telling patients it is very difficult when you have a new baby at home to remember to take a pill at the exact same time every day. And that's a bias I can bring into the conversation with that as well. So let's go through the data about a few different forms. So progesterone IUDs are probably the most talked about LARC option. I think that we as healthcare providers have an inherent bias, as it's the most commonly used form of birth control in healthcare providers. And that it's also thought to be extremely effective and generally has pleasant side effects like decreased periods and fewer adverse side effects. However, in general, small studies, there's limited systemic absorption and thought to be less risk. There are studies that say delayed placement of the progesterone IUD is unlikely to have an effect on breastfeeding patients. There's insufficient and conflicting data regarding immediate postpartum insertion and effect on breastfeeding, given the overall small number of studies and just small numbers of patients included. 2 studies did not show any effect of the IUD on breastfeeding, while one study with an overall low rate of breastfeeding in the patients showed an adverse effect on immediate IUD placement. The number of patients enrolled in these studies, again, were low. And one of the general problems with literature on this topic is that the endpoints are so varied. So in some studies may look at things like overall breast milk production, some may look at things like sustained breastfeeding, some may look at markers of breast milk passage. And so it makes this data difficult to interpret. As Dr. Stubbe et al. Astutely points out, the limitations of studies on the immediate postpartum LARCs, including using breastfeeding as a secondary rather than a primary outcome. They also select a non-inferiority margin that may in fact represent a clinically meaningful decrease in the context of hormonal contraception and breastfeeding. If you're a fan of statistics as I am, we know that clinically meaningful and statistically significant are not always the same number. And that's very important when we think about person-centered counseling. For a woman or a patient who strongly desires to breastfeed, even a very small risk of iatrogenic failure may be clinically relevant or clinically unacceptable. And it's important we mention this. I think this topic will likely be the most important or largest time part of this conversation as far as LARCs go and as far as breastfeeding goes. So I'd like to save room to finish talking about the evidence on other methods before we circle back to progesterone IUDs. As far as the contraceptive implant goes, this is probably another favorite of many healthcare providers, especially given the ease of placing it, the fact that it can be done in the hospital prior to discharge. For the implant, the brand we know as Nexplanon, the preponderance of the data suggests there is no impact on breastfeeding. However, there are limitations to that data as well. Definitive conclusions regarding the effect of the etonogestrel implant on breastfeeding are not possible due to very small study sizes. From what I could find, none with more than 100 patients. There are a total of 4 randomized control trials published regarding early insertion. The arms of those RCTs range from 12 to 48 patients, with one arm being an early insertion and prior to discharge, and the other arm varied at time of insertion. The outcome of interest varied between studies again and included heterogeneous topics such as lactation failure, breast milk volume, newborn weight gain, and breastfeeding rates. Statistical differences were not elucidated in these. So that's just to summarize that. I have some additional information about those studies that if people have questions, we can provide resources. Finally, the injection, most common being Depo-Provera. Data is also limited regarding lactation and Depo. One study showed a possible detrimental effect of Depo on duration of breastfeeding when administered immediately postpartum, but did not reach statistical significance. Several studies suggest that patients administered Depo within 72 hours or later actually had maybe an increase in lactation. And one study only looking at an endpoint of prolactin levels suggested increases in prolactin may explain why some patients experience this increase. With the injection, again, the data is mixed. The endpoints are varied and cohort sizes are limited. With the injection, one of the major problems is that once it's administered, it cannot be reversed and can also have an effect on things like ovulation and trying again for pregnancy for up to a year. Many populations have not been studied, such as prematurity, multiple births, and conditions of the parent or the newborn. So that's really the major data I have as far as the different methods. If you look up these studies, which, I went through, it's really interesting just looking at how heterogeneous they truly are. And many of them quote other studies that use different clinical endpoints, which is sort of like one of the only no rules of statistics. So it really is kind of hard to wade through all of this data, and it's constantly changing. So what do the major health organizations say? The CDC and the WHO categorize birth control methods by assigning a numeric category. According to a wide variety of health conditions and changing by the method, these are reassigned in every MEC. The key in the chart is essentially the same for the CDC and the WHO. For lactating patients, the CDC categorizes the implant, the injection, and progesterone-only pills as category 2 when initiated at less than 30 days, meaning that the benefits generally outweigh the risks. It categorizes the same methods as level 1 or no restrictions for greater than 30 days at initiation. There is no comment on the levonorgestrel IUD. The WHO, interestingly, categorizes the implant and progesterone-only pills as category 2 for less than 6 weeks, and the injection is category 3, or risks generally outweigh the benefits. However, the rationale for the level 3 by the WHO is clarified as due to animal studies related to brain development in animal models, not in relation to change in milk supply. I didn't know that until I looked this up. The WHO categorizes the injection and progesterone-only pills as category 1, greater than 6 weeks postpartum. It has been proposed that the WHO guidelines tend toward higher numbers for lactation because they are more invested in milk supply for the global population. We are lucky to live in a country with generally safe water and formula, and therefore breastfeeding may be seen as a lesser priority than in the global population, where this is not always the case, though it is an important and necessary public health movement. While the CDC tends to have lower numbers, likely representative of the unintended birth rate in the United States approaching or surpassing 50%. What I take away from this information is that the data is poor and everyone, including major health organizations, have biases and unique perspectives based on the population that they serve. So to dig into this a little bit more, and am I doing okay on time, Katie? Okay. There was also a Cochrane review that was done with 11 trials looking at combined hormonal versus non-hormonal versus progestin-only contraception and lactation. And there was also guidelines put out by the Academy of Breastfeeding Medicine. This Cochrane review, published in 2015, looked at all of the above, and in the 11 trials included, again with heterogeneous results, the results were mixed. And the conclusions of the authors was that evidence was limited on any particular method and its effect on lactation. The Academy of Breastfeeding Medicine acknowledges a theoretical risk that cannot be confirmed due to insufficient data. They do specifically note that the injection cannot be discontinued or removed if milk supply is reduced, and therefore this could be a rate limiting factor. So how do we approach this? After we've all looked at all of the data, we've read all of these articles, we could say that the results are heterogeneous all we want, but we all know, as my former co-fellow Jeff Gordon said, the way he reads abstracts is he looks at the conclusion, decides if he agrees, and then reads the rest of the abstract. I don't think that's the right approach, but I think we all do that to some extent, right? Whatever our bias is, we'll find evidence that supports it. And how do we bring all of this together? So I think, again, to go back to this article by Stubbe et al., they summarize it quite well. The limitations of the evidence on contraception and breastfeeding leave the existing data open to a range of interpretations. Interpretations are often seen through the lens of the interpreter, leading to conflicting and disjointed care. The preponderance of evidence over 50 years shows that hormonal contraception does not reduce milk production, nor does it show that hormonal contraception adversely impacts breastfeeding, despite the biologic plausibility of that effect. However, these findings may not always be applicable to the complex, heterogeneous postpartum population seen in the United States. Heterogeneity in study designs, populations, and outcome limits and interpretation of these results affect our ability to interpret. For example, most studies enrolled women with healthy term infants. None evaluated women with extremely premature or low birth weight infants. No studies have evaluated women with a variety of risk factors for difficulties with breastfeeding, such as women or pregnant patients who have exclusively pumped breast milk, as opposed to feeding or chest feeding, who are morbidly obese or have hypertension and diabetes, which I think we all know is a vast majority of our patients. And again, for a woman or a pregnant patient who strongly desires to breastfeed, even a small risk of failure may be clinically relevant, if not statistically relevant. My favorite part of this whole article, and I do encourage you all to read it, is, and this is a direct quote, "It is important to convey a deep knowledge of the literature and its limitations with respect to cultural, historical, and socioeconomic background. There is a way forward, and offering a patient-centered and person-centered approach to care is it." This brings in two experts to the conversation: the patient, who is an expert in her own life, her goals, her experiences, and her values. You, the provider, who is an expert in contraception and breastfeeding and providing optimal care. I think if we approach these conversations using both of these people as equally important experts, then it will change the framework. After reviewing the available data and meeting with a variety of experts, as Dr. Sampene has done over 2 years and thousands of conversations, we would like to propose communication with patients in the following manner that you see above, which will also be shown when we review resources that are created for this project. When it comes to the risk of decreasing milk supply, the progesterone IUD are low risk right after birth and no risk after 6 weeks. For the contraceptive implant, it is low risk right after birth and lowest risk after 6 weeks. For the injection, it is low risk right after birth and lowest risk after 6 weeks. Specifically, some may actually experience increased milk if given after 72 hours. This is what we would maybe call an oversimplification, but I think it provides an important framework and conveys the quality of evidence that we have available about these methods. So with that, I will wrap up my part, and is the break now for questions?
I have 2 more slides.
Okay.
And then we're gonna give you guys a
Sorry.
bio and coffee break and all that good stuff. Oh, we can, so, okay. So the last thematic item that we addressed during this project was that some patients experience difficulty in getting LARC removed due to a provider encouraging them to keep the method or refusing to remove it. While we recognize this is not often a problem during pregnancy or the postpartum time period, it's included due to thematic relevance with our project. So there may be many reasons to be enthusiastic about the implant or the IUD. There's also a concern regarding access for removal. I wanted to highlight this study from Dr. Senderowitz. The population here was African, but other data is akin to our own here in the US. The themes arising from this publication include a sense that providers are gatekeeping and requiring patients to have a compelling, legitimate, or medical reason for removal. A simple desire for discontinuation was not sufficient. That being said, today we're remembering, we're not going to throw the baby out with the bathwater, but we're also going to consider the need for improvement. Providers should still seek to understand patient requests and provide options to those who have an ongoing need for contraception. Every effort should be made to honor the request same day, as multiple visits for a removal places a really significant burden on our patients. An example of a provider response could look like, I'm happy to remove your IUD or your implant today. Can you share with me what led you to want it to be removed? By starting with a statement that I'm happy to remove it today, hopefully it informs your patient that they're not going to be required to convince you or be deemed worthy for removal, but rather that you seek to understand and meet the patient's needs. So thank you for your attention. I want to give a couple minutes to open it up at this break time here for question and answer, and then we're going to do bio coffee food break for about 5 minutes after that, before we move into the second half of our presentation. If there also is anyone that wants to speak up online or put things in the chat, we're happy to communicate that way as well.
Yeah, hi. Thank you so much, Katie and Jackie and everybody for putting this together. It's just been a labor of love, and I've already learned so much. And I'm glad I said, hey, you guys can have 2 hours because I'm looking forward to the second half. I have a couple questions, one for you and then one for Jackie. And I guess even my first question is, did you learn in your research whether patients like you to refer to it as birth control or contraception? Because there's a lot of movement out there to just make sure we're using language that patients want to hear. So that's one question. And then I just have a quick comment about counseling. So do you call it birth control or contraception? Did you learn anything about what the people out there want?
I actually didn't read about that.
Okay.
It looks like Dr. Higgins just walked in.
Oh.
Oh, true.
Okay. All right. Yeah, some people don't understand the word contraception. Anyway, I'm curious about that. And then the second thing is just as a comment, obviously this isn't my space, but I think one of the keys when we're doing all these multiple providers with the patient is just what you said. People get asked the same thing over and over again. And there's just so many subtle changes in our communication, our patient provider communication that can help. Which is, just to say, do you want to talk about contraception? It's just so subtle. But my personal experience in the healthcare setting is that I was asked, I can't tell you how many times, what contraception are you using? And I've never needed contraception in my life because I'm in a lesbian relationship, right? So that's just a really subtle turn of phrase. Do you want to talk about contraception? And then when we're cross-covering so much with people, I do this all the time in my practice, sort of, what have others told you? Or have you had this conversation with the other providers? And it's just super quick because if they say no, you're just on to the next thing. So that was just a comment and a question. And then for Jackie, again, this is in my area, but it just seems like it's kind of ripe for like a 2-week visit. Like, has anyone ever thought about, let's not, do these LARCs and implants, in the hospital. Let's let people, sort of get home and get their breastfeeding rolling. I mean, the first 2 weeks after birth are like the most difficult in the history of your life. And so I think getting that, if breastfeeding is so critical for people, why aren't we moving towards this? We're going to check in with you at 2 weeks. When we have this concept that like, oh, you delivered, you're fine, you're good to go. There's no medical problem. Call us if you have trouble. But there's just so much care that people really need in the postpartum period. So do you have any comments on that?
Yeah.
Give some enthusiastic.
Okay, maybe
interest
I'll
in-
wait. People have,
We did this work.
Yeah.
We worked really hard to get contraceptives covered, long-acting reversible contraceptives covered in the hospital. And the reason we did it is because people don't get them. If they don't get them in the hospital, they don't come back. That's why. And then they have a really high rate of unintended pregnancy. No, even at 2 weeks. Yeah. People don't come back. People don't come to postpartum visits. Right. It doesn't matter what duration of time. If once you're out of the hospital, you're out of care, your risk of not getting contraception is significantly lower.
I will say my one comment to that is ACOG actually changed their postpartum guidelines and recommends a two-week visit for every patient now, but
in the first 3.
or, oh, sorry, you're right. It's within the first 3 technically. Which, you know, in the high risk clinic happens quite frequently because you almost never make it out of our clinic without a C-section, high blood pressure, or diabetes. And so most people are getting seen either by telehealth for an incision check, something. And so we have that. It's unfortunately the patients that are maybe lower risk that then don't get seen for 6 weeks, excuse me. So
Or never. There's a very high rate of
Or-
non-attendance.
yes, exactly, or
It's
never.
40 to 60% of people never go back. They never get seen postpartum. I didn't go to my postpartum visit because I was a resident. I didn't have time for that.
The UW midwives do see patients too, or we offer a patient visit at 2 weeks. I also didn't go to my postpartum visit. And my name is Hannah Kopp. I'm one of the UW midwives. Also, we have to think about when women's insurance runs out. And I know it's another factor and we have to think about so many things, but lots of women don't have, they only have insurance during pregnancy. So 2 weeks or immediately postpartum. That's all.
And I think traditionally, there had been this thought that maybe we need to wait for the uterus to be less soft after the birth. Maybe we would have more perforations if we did it at 2 versus 4 versus 6 weeks. But I think all of these are good points. I would encourage us to like refocus on person-centered, which is really hard. We have a lot of limitations in the time that we can spend with patients, but if you understand for your patient sitting in front of you, are they going to come back? Can they share with you if they're going to come back or how that would work? I think part of this is like trusting that your patient has some experience that they know about themselves and that they can communicate that with you if we're willing to listen. And so I would just, all of these points are super relevant, and then just focus on your patient in front of you.
Can you
Okay.
guys hear me online?
Yes.
Are you guys able to? This is Molly Lepic. I think this has been great. Thanks so much. I had just 2 quick comments and one's a question more. I think that as we work with our like rooming staff as well, it's a good area for you to like think about how you work with your faculty or with your staff, because I know a lot of times my LPN will come out of a room and be like, oh, she thinks she wants birth control pills for birth control. And so like, she's like started that conversation, which might not always be well received depending on the patient. And sometimes she'll come out and be like, she doesn't really know if she wants any contraception, wants to discuss with you. So sometimes like she brings that up, which I think can be really helpful as a, sometimes not a doctor bringing up that conversation, but I think could also sometimes be detrimental in terms of like, if she's asking and then I'm asking. And so I think that that's like an area that we can all individually look at our practices to see if there's a way to, streamline that. And then my second question too was with the lactation component and birth control. Perceived milk supply issues are a common reason for breastfeeding cessation or inclusively feeding with formula or donated milk, which then kind of is a cycle of not pumping or providing as much breast milk from the patient. Is there anything that we saw in the literature about perceived milk supply after progesterone contraception?
I don't know if any used perceived milk supply as the endpoint. I saw endpoints like expressed volume, pumped volume. There was actually one study where they put a biochemical marker in and they measured how much the baby was taking in. It's a good question because it's the perfect storm, right? We always say that, started at 6 weeks and then if your milk supply goes down, but many things are happening at 6 weeks, right? Maybe parents are going back to work. And they're having to switch from exclusive chest feeding to pumping. It may also be that if their baby's having weight gain issues or something, they've been supplementing, things like that. So maybe someone knows a search, or I didn't see anything in my literature reading about perceived milk supply per se.
An internet study that's like a click to answer study that did show a high incidence of people perceiving that their birth control decreased their milk. But that study obviously has all sorts of so it biases toward folks that.
I don't know if you could hear that, Molly. Eliza said that there was one online study that was a click study of perceived milk supply that patients could put in directly, and that did show a decrease in perceived milk supply. So I'd really like to link to that if you find it.
Yeah, I mean, everybody thinks they have low milk supply, even people with oversupply. Babies are fussy. Babies are so hard in those first weeks that even if they're growing and peeing and crying and you're leaking everywhere, people are like, maybe it's my milk. It's just the natural cycle. Thank you, guys.
I'm gonna let Eliza do a last.
I would wonder if you looked at differences between locations where breastfeeding is the norm versus the US, where breastfeeding is not necessarily the norm, especially in some populations. It's really low rates. And whether, I just feel like we malign birth control as the cause for poor breastfeeding outcomes when there is a large volume of evidence that would show that there are many cultural reasons, perhaps physical reasons, that breastfeeding doesn't happen at the rates in the US that it does in other places.
Yeah, there's actually is one good one that I'm aware of. I think it was in Malawi. And I can't remember if it was either the shot or the implant. And their breastfeeding rates were like 100% up to like a year afterwards. But also if you don't have clean water or formula, like there's not really alternative choices, right? So you're in a rock and a hard place. So that's a very good, thought-provoking, interesting point in this whole complex situation. I'm going to pause there. So it's 8:07. We're going to be back here in our seats around 8:13 to be very specific. So I'm going to start us off then in about 5 minutes and get us going again. So go ahead and get your bio break. So now that you have some background regarding the identified concerns with contraceptive counseling, we would like to share with you some tools that we developed today. The background on this tool is the one key question contraceptive counseling model. The one key question counseling model was recommended in the Saving Our Babies report, which was a Dane County Health Council community engagement campaign. And it was focused on the African-American low birth weight crisis in our community. I was also able to take the one key question training, which is aimed at optimizing contraceptive counseling and minimizing bias. The one key question is, would you like to become pregnant in the next year? The one key question is specifically not recommended for pregnancy or the postpartum period, as many of us can recognize that that's not a question that makes a whole lot of sense. Therefore, we used the principles from the one key question and tried to make it relevant for the pregnant and the postpartum population. This is something that we propose could be used at the 28-week visit, or when you're planning to address contraception or birth control with the patient. Akin to the workflows that many are familiar with for depression screening, the patient can work on this while they're awaiting the provider. Then the provider can use this information to guide a conversation. Some practices may use a paper form and scan it. Others might want to do an electronic version or a dry erase laminated version. You'll see at the top that we have, would you like to become pregnant again within the next 3 years? Then we have some answers the patient can check. I'd like to point out a simple thing that is not always readily apparent to providers, nor was necessarily totally understood by myself prior to this training. But being unsure or okay either way is normal, and the answers might change over time. Many of us providers have classically thought that patients better figure it out. Are they a yes or a no? If not, the conversation might be at a standstill. Or if they're an unsure and okay either way, many of us kind of classified that as no. It is going to be a common response from patients. And on the left-hand column below the hashed line is some thought-provoking questions for the patient to consider how they would feel if they're pregnant again, the timing, and how important it is for them to prevent pregnancy. If the patient has checked unsure or okay either way, you may particularly want to use those questions to help guide your conversation. You will also notice there's permission questions, acknowledging that some patients may not want to discuss the topic at that visit. And it provides you a respectful way to help you understand this. The right-hand column is a list of common patient priorities as it relates to contraception. You'll notice the terminology of chest or breastfeeding again to promote inclusivity. Briefly, other priorities include effectiveness, period changes, side effects, impact on sex life, ease of use, privacy, past experiences, timing of the start, cost and coverage, and religious beliefs. We plan to have these resources available both in English and Spanish language, but it is going to be however long it takes to translate before the Spanish versions are ready, and we'll keep you all posted on that. The next tools are informational. We would encourage you not to think of them as the classic handouts, but rather tools. They can still be handed to patients, but will be most effective if coupled with a conversation that's tailored to your patient. This first page is a common question and answer style and addresses birth spacing, lactational amenorrhea, safety of methods with lactation, timing of initiation, what happens if you have sex without birth control, facts about emergency contraception, and finally sterilization. One thing that we were particular about in the development of this tool is the explicit guidance on lactational amenorrhea, which is using breast or chest feeding as birth control. We carefully outlined the requirements for feeding to function as birth control. This includes feeding at the breast or chest rather than pumping, feeding around the clock without gaps. It assumes no supplementation is necessary, that you don't menstruate, and that the baby is less than 6 months old. If any of these items are not true for a particular patient, the efficacy will be reduced. The FAQ section also outlines in more detail the use of birth control with lactation, as we discussed earlier in the presentation. It shares information and options for those who are not contracepting, including pregnancy risk and emergency birth control. Finally, we were careful to include the Medicaid requirements for sterilization, an issue that can be a real barrier to care. Additionally, many of our patients are interested in information regarding vasectomy, and this is outlined. As another tool, we have provided the contraceptive option information in chart form. Since different patients process information differently, this type of visual tool may be helpful. Again, we encourage this use as part of a conversation. Patients and providers may find that writing on it, highlighting it, circling options that are good for the particular patient would likely be more effective as a strategy than if just kind of handed to the patient as part of a packet. Yeah, absolutely. Dr. Higgins was just pointing out that one of the things that we have talked a lot about in the development, which is that there's a lot here and it's hard to see on a screen and it's a lot of information for patients. I will share, we went back and forth many, many times about how much to include and what to cut out and how to be comprehensive, but easy to read. So here we are. The chart is arranged with one page of non-hormonal options and the second page of hormonal options. The methods are organized from left to right according to effectiveness. The left column outlines common points of interest regarding the methods, including the details about use, discontinuation, milk supply, side effects, risks, benefits, period effects, and sexually transmitted infection prevention. These we plan to very, very shortly, hopefully within days to a week, have a QR code on these materials that will be able to link to the Meritor education site. And that way, some practices or providers may like to have like a laminated copy or something that many patients may wish to scan with their device, link to there where we can save some trees, can still have paper versions for patients to, have for their use. And then additionally, that central repository can serve as the place where practices know they can get the most up-to-date version, as we acknowledge there may be things we need to edit, change, update as we get more data or input over time. Dr. Higgins, does that help? Okay, yeah. To be able to effectively teach our patients, consider that individuals may favor a particular learning style or benefit from a mix of learning styles. We anticipate that the resources shared today will help to meet many of their learning styles, including visual, auditory, reading, and writing styles. Most practitioners have pictorials or hands-on models in their offices, but if you don't, we do encourage the use of those types of learning aids as well. Patients often better understand their choice if they see a model of a device that they're able to touch or feel. We also recognize that digital media and videos are very effective tools to meet patient needs. And while we don't have those types of materials prepared for you today, it could be an exciting opportunity for future improvement projects. You may be thinking that all of this information is great, but you live in the reality of the 15-minute visit. So as always, we do need to consider what we can address today at a visit and what needs to be addressed at a future visit. For some patients, this will be a really simple and quick conversation, and for others, it may span several visits. Patients can be encouraged to continue the conversation with support systems, including doulas, community health workers, or others that may be engaged in their healthcare. And now, Dr. Berghahn is going to lead us through a case study. Dr. Berghahn is splitting up our resident doctors into groups, and our wonderful online folks are going to be split into discussion groups randomly. You'll probably be in groups of 3 or 4, so online to have a small group discussion. But we won't split you up quite yet because Dr. Berghahn is going to present the case and let you know when that split up needs to happen.
Okay, thank you so much for asking me to be here, Dr. Sampene. So we're going to go over the first case and then break up into groups. So this is a 17-year-old, a G2P0 at 28 weeks, a history of one therapeutic AB 6 months prior to conception, history of trichomonas treated last year, history of chlamydia treated in early pregnancy, tried the pill in the past but forgot to take it, and patient reports plan is to abstain from sex in the future. The patient fills out the form at the 28-week visit and checked no, does not want to become pregnant in the next 3 years, and checks no, does not want to discuss birth control with you today, and no, does not want to discuss birth control at a future visit. In our small groups, we're going to go over what is your initial reaction, what is your response to this patient, and what are the words you will say to the patient at today's visit. Okay, so residents, I'm going to give you 5 minutes. You're going to elect a spokesperson in your group to answer to share with the audience your best answer for each of these 3 questions. And then for my elite row in the back there, yes, the back row, you have an extra challenge here. You're gonna have to say something that hasn't already been said. So you're gonna have to maybe come up with 3 or 4 options for your answers. I have a prize for everyone who agrees to speak. And the back row, you can phone a friend if this gets difficult, and everyone in the back row gets a prize. If you can give me an answer that hasn't been said before. All right, so I think we're going to break up for 4 minutes. Please, other people in the audience, partner with the person sitting next to you. People joining us virtually, you'll be put in a chat room, and anyone can speak up if you have insight and want to share something as we go along here. All right, so 4 minutes.
All right. So our group discussed that our initial reaction is really driven by our provider biases of wanting to, in the most evidence-based way, help this patient reach her goals, which if her goal is to not get pregnant in the next 3 years and she doesn't have a plan to use any specific form of contraception, we said our initial biases were that that's not going to work. But that's not what we would say to the patient. And we talked about ways to kind of tactfully try to get an understanding of what that patient's plan is beyond just abstinence, or what abstinence looks like for her. So asking her kind of what her plan is in terms of situations that might arise in which it'd be difficult to remain abstinent, if she had thought about forms of contraception that would be that she would be interested in using, and what she would plan to do if it wouldn't work. And just really normalize that some people choose abstinence and that's okay, but we know that it's really hard for people to maintain and it doesn't work a lot of the time. And just normalizing that and offering her any opportunity to have that discussion again in the future.
That's perfect. And then the last one is the hardest question. What are the exact words you're going to say to the patient? Imagine the patient's in front of you. What are you going to say at this 28-week visit?
Yeah, I think the exact words.
Hello, Becca.
So the exact words I would use would be I noticed that you desire not to get pregnant in the next 3 years. I think that's, a great decision, and you chose to abstain from sex in order to achieve that goal. How would you plan to approach that in a situation where you might be thinking about having sex? And I would ask her.
That's great. Yeah. Will you pass the mic on?
Hello. Our group talked about our initial reaction would be okay, these answers don't make sense. This is not logical. We would be concerned and feel shocked a little bit with our initial biases coming through. And then we would want to learn more about why the patient chose these answers, and if she has an understanding of what contraception is or what the form is really asking. Our specific words that we would say would be to maybe start off with, let's just review this form that you filled out. Instead of, straight away talking about birth control, if she's marked specifically that she doesn't want to do that at this visit or any future visits. And then just asking like, what is your reason for selecting these options? And then keeping it open-ended, letting them know that they can always, if they change their mind and they want to discuss more, that they can. And just touching base and asking the patient, like, what are your long-term like reproductive goals? And, if, and making sure that they understand like what contraception is as well, because we discussed earlier, not everyone like knows what that word means. And so being cognizant of that.
That's really good. We pass the mic. Okay, this is going to get more challenging. I'm going to start asking you questions. I was easy on the first and second years. All right, so what is your initial reaction? And that it is okay to say what your bias is, because we're human, we all have it. We have to just recognize it.
Yeah, so our bias was that similar to, I guess, the other groups, that we didn't think abstinence was a good plan for this patient. And we felt like they needed contraception. Also, like when we were reading the prompt.
And how
And-
does that make you feel when you feel like the patient needs something?
Yeah, it feels like we shouldn't be having those feelings. But we are, and recognizing that I think is very important. And then also recognizing that we thought that that plan probably has a high risk of failure, just given what has happened in the last, 6 months with that plan. Likely
And
was.
does this make you feel like frustrated? Like what is your initial gut reaction when you see that this is the next patient you need to see? And you might have delivered a baby at 2 a.m. You might be 15 minutes behind. Like what honestly is your reaction?
Like I feel like I said, I just think that this person needs contraception. Like, and I don't, like everyone else has said, don't think that the answers are very like concordant
Right.
and logical. Like saying one answer up top and then completely opposite
Right.
answers in the form below.
So how do you want to respond?
Well, I think like what Awa and I were talking about was like recognizing those feelings before talking to the patient, and then making a plan to better understand, where those thoughts or that logic is coming from, I think is really important. Because like we don't know what this person's experience has been with the healthcare system previously. We don't know if they've had, interactions with providers where they've felt pressured for contraception in the past, and that's why they don't want to talk about it today. So recognizing those things beforehand.
And so who can you turn to if you're getting this sense that the patient isn't trusting you?
Maybe like the person that roomed them could be helpful, like in figuring out like what was their like sense, like what was their vibe when you like roomed them, like did they say anything to you about filling out the form when you handed it to them or something like that?
Can you think of referrals?
Like referrals after your visit with them?
If you think they're not going to trust you to have this conversation.
Oh, like their
yeah.
primary care doctor, anybody else, I guess, that they've seen in the health system, which you can ask the patient
Right.
to, like if there's a provider that they've seen regularly or other people.
Or if they have a doula,
Yeah.
or if they want to bring a friend, a trusted adult, a partner, a family member to like future visits. That is a big thing that we encounter is patients like not having trust in us. And that's the reason they don't want to talk to us. And especially adolescents are much more likely to make contraceptive decisions based on what their friends are recommending to them rather than a doctor that they don't trust. Okay, and then what are your exact words to the patient?
Yeah, so we were gonna just thank you for filling out the form. And like, would it be okay if we talked a little bit more about the answers that you provided? I can see that you don't want to discuss contraceptive options today. Would it be okay if we gave you resources, today, or, the option to talk about it in the future?
Yeah, that's perfect. All right, last row.
So one of the things we talked about, our initial reactions were the specific pieces of the prompt ties into all of our provider biases about the risk factors for unwanted pregnancy, for previous treatments, and some of the social pressures that are put into place, especially with previous abortion, and what that might mean for that particular patient and what they're experiencing in terms of the pressures they're feeling societally. And we won't know those things, but the biases that I bring in is that we want to treat, we want to help, we want to fix or solve a problem with all of these aspects in it, which may not directly align with the reproductive goals of that particular patient. And so, and then when we see the discordance between their desire and their desire to not become pregnant, but then their lack of desire to have some sort of intervention to help achieve that goal, it ends up, we go into like problem solver mode in those moments. And sometimes that can blind us to understanding some of the more difficult nuances that that patient would provide.
And does this case, a 17-year-old who's like not opening up to you, does that make you think of like, what are the other things that possibly could be going on? And how could you address that?
Absolutely. And I think of like my particular response as a white cis male provider in a reproductive medicine setting. There already feels to me like a general distrust, or there's a higher barrier to overcome that level of trust. And I think when you approach it that way and seeing someone put answers down on the sheet of paper, understanding your resources and understanding how to overcome that basal level of mistrust is imperative. I know that there was a group of adolescent advocacy groups for medicine that we had a Grand Rounds with 3 or 4 months ago. I forget the name off the top of my head. Patch.
Yeah.
Which would be a great resource in terms of our own personal education and understanding those referral sources, as you had mentioned earlier, to understand how we can overcome some of those general levels of mistrust in our positions of power in this dynamic.
Yes.
And so understanding that and then really understanding where the patient is coming from is a really important piece of this puzzle.
So he brought up Patch. Patch is a program in Madison where high school students are trained to become advocates and teachers to healthcare providers on how to connect with teenagers and how to talk about contraception and how to talk to a diverse group of adolescents. And so you can hire them to come to your clinic to talk to you. And so that is a great resource. So I have had several patients like this in my career. One of them shared with me that her mother had just died, but I had seen her for 2 months before she felt comfortable enough to tell me that. I had another adolescent share with me that she had been sexually abused by a healthcare provider. Again, took her months for her to share that with me. She was so afraid of the thought of strangers doing cervical exams and labor that her mind wasn't on contraception, but it took months for her to feel comfortable to tell me that. And what I learned from those 2 patients is probably most patients have something going on in their life that you may not comprehend because they don't feel comfortable sharing with you. And you can have empathy for people, for human beings, even when you don't understand what's going on. The other thing, I'm not done grilling you here, and I'm sorry. If you think there are mental health issues going on, if you could give me a differential of the possibility and how can you screen and how can you refer out if you have an adolescent that you're concerned.
I mean, we can do an IPV screening for sure. One of the things we would just see is if they feel safe in a relationship that they're currently in, truly understanding what their, I mean, hopefully at the 28-week mark, we would have had this information already from previous prenatal visits, but
they may not answer truthfully until you've gotten over this barrier where they trust you. yeah,
Absolutely.
Go on.
And so that's one thing that I would be thinking, and then we can, if they screen positive, do a brief intervention at that point, and then can refer to behavioral health services, work within our department, and be able to try to follow that up specifically if
Yeah,
that
and
ends up being.
specifically, there's the Edinburgh for depression, there's a GAD for anxiety, there's domestic violence screens, and there's the substance abuse screens that can be done. One of the hard things is actually getting them to mental health because of a shortage in the community. And I just want to put a plug in for the Periscope project, which is Medical College of Wisconsin psychiatrists are available from 8 to 4:30 to take our phone calls. I've called them several times. They have helped me figure out kind of the first steps while that patient's waiting to get in to mental health services. But that psychiatrist wants to know a lot of questions, and like you need to know that patient and what they're going through in order to answer those questions for the psychiatrist. You did great. You checked off all the points I wanted to make. I'm just going to go over some statistics. So this is from the American Academy of Family Practice. And teen pregnancy is considered a problem because these patients are less likely to graduate from high school, more likely to have low self-esteem and symptoms of depression, increased behavioral and substance use concerns. Children of teens are at greater risk of preterm birth, low birth weight, child abuse, neglect, poverty, and death, and have high rates of public assistance. However, researchers in this area inform me that it is not teen pregnancy alone that's an independent predictor of these adverse outcomes. The number one predictor is childhood extreme poverty, extreme economic deprivation while growing up is the reason people have these adverse outcomes. All right, about 43% of teens aged 15 to 19 have ever had sex. I don't know about you, but I have a 17 and a 20-year-old. And if a research study involves them having to do something and fill out a form correctly and have to turn it in on time, it's like a 50-50 chance this gets done. All right, so it's just one thing to think about in studies, whether the study actually reflects our general population. 4 in 5 teens report using birth control the last time they had sex. Over 50% of them are only using condoms. Less than 5% of teens on birth control use the most effective types. Just some more statistics here that I find fascinating. The teenage pregnancy rate in the US is lower than it was when I was a teenager 30 years ago, but still higher in the US compared to other industrialized nations. And it's expected that after Dobbs, the birth rate will increase. A common statistic is that 25% of teenagers in the US become pregnant before the age of 18, and 1 out of 3 of them will be pregnant again within 2 years. This affects everyone, every race, ethnicity, but the burden falls disproportionately on families of color. Adolescents who do not use contraception postpartum cite fear as the number one reason, fear that the birth control is permanent, fear of long-term side effects such as pain, fear that it's unsafe for breastfeeding. So one of the problems for us is we get all this information in med school, but then like you're charged with going to the bedside and talking to the patient about these issues. So so what you say, and my disclaimer is that the mental health provider that I employ who works right down the hall from me, like wrote this for me. So this is what he suggested to say to this patient at the 28-week visit. First of all, thank you for filling out the form. I want you to know that I'm here to support you. I respect that you don't want another pregnancy in 3 years. This is your decision. But my concern for you is that I see a lot of patients who use abstinence and it doesn't work out great in the long run. So we don't have to talk about it today, but I do want to hear your thoughts about this at a future visit, and perhaps when your doula can be with you, or if the patient doesn't have a doula, refer to Harambe Village or Roots for Change. There's numerous other organizations out there. And then when you are ready, we will review all the options. And then would it be okay if I updated your doula on what we talked about today? You can get permission from the adolescent to talk to their trusted adult. The other advice the mental health counselor I work with says is make sure you're creating a safe space for teenagers. Ask open-ended questions to get them to talk, and don't have the question be, what are you going to do after high school? That's an extremely anxiety-provoking question, and just might show the disconnect between you and what this teenager is going through. So open-ended questions: what are you looking forward to when the baby's born? What are you most afraid of? How do you feel about contraception? What are your thoughts about getting your doula or some other trusted adult in here to talk about it with you? Provide accurate information. It is your job to provide information. That is not a bias. That is your job, but it is not your job to make the decision for them. Okay, so this patient does, in my eyes, doesn't get off the hook about not ever talking about this ever again. We're not going to talk about it today. We're going to wait till this patient is ready to talk about it. But just like a patient who declines vaccines, I often tell the patient, this is your decision, but it is my job to give you accurate information about vaccines. And it's my job to actually document it in the chart that we talked about this. And so I have to do this. And most people are okay with that, even if I know they're gonna decline. Explore the goals and preferences of the patient, empower the patient. Teenagers wanna make their own decisions. And Dr. Hartbach and I were just talking about this method actually helps you as a doctor. I see in my 20 years, I've seen a lot of doctors get so frustrated dealing with patients that are not adherent and not following recommendations. That is not your job. Your job is to provide accurate information, help them make decisions, but ultimately the patient is the one making the decision, even if it's something that you don't agree with. And that has helped me not get frustrated and burnt out. And that's really important, that this cultural humility, person-centered care helps you as a doctor. All right, the last slide here is the documentation slide. So we're asking attendings to fill out the problem list in a spot where it's really easy for residents to find what the plan is. We wrote for the plan for contraception. This was discussed 7.1. See clinic note, patient plans to abstain, does not want to discuss again, but okay with me discussing with the doula. And then we're asking the residents to only bring up contraception to the patient in triage if the plan is a post-placental IUD or sterilization. Okay, so a huge thank you to the residents. This is hard. Public speaking is hard. This is a hard case. This is a really hard topic, and you guys have a really hard job. You have inherited a healthcare system that is failing to take care of all people, and we have to do something about that. And I am not an expert at what the solutions are. There's so much for me to learn, but what's really important for me as a private practice doctor is to show 100% support for efforts to dismantle bias and racism in the care that we provide so that we have good outcomes for all people. So thank you.
Thanks, Dr. Berghahn, and for everyone who has participated. I know we had online groups as well. Thank you. I hope your conversations were good. And I wish we had endless time today, but I'm going to go to our conclusion. And we're blowing through some cases because we had such a good one. We wanted to focus on that one. So now that we've had the opportunity to kind of work through a case, I do want to circle back around to conclude about our project as a whole. So we want to keep in mind that we've been working on this quality improvement project to improve essentially the patient experience. We've done our P, which is the plan of the PDSA cycle. We're moving on to the D, or the do phase, to disseminate this information in the resources that we developed. And for the S, or the study phase, we plan to assess our patients' experiences. So we've been collecting pre-intervention surveys on the postpartum floor, and we plan to compare the patient responses before and after our intervention. We recognize that there will be many interesting survey questions that, or there could have been many questions we could have included. But we ultimately hope that our survey will let us understand what we're doing well and what changes we need to continue making moving forward. I do owe a huge thanks to our merit or lactation consultants who helped to distribute and collect the surveys as they see all of our patients postpartum. Finally, there is the A or the ACT of the PDSA cycle, meaning that we'll probably find our post-intervention surveys still have some room for improvement. That's expected. We probably won't have it all perfectly or correct with kind of one cycle. And we do remain open to reflecting on our patients' experiences and further tweaking or adjusting in the future as we gather this data. The resources that we've been working on, I do have contacts at all of our practice groups and locally. And so we're going to let folks know as soon as the QR code is available to link you to that site for easy dissemination, as well as when we have the Spanish translation available for all of our patients, which is super important. Huge thanks. So many people to thank, and I won't go through them all today. Many are listed here on this slide. We are really at time. If folks would like to stay on or ask questions or give comments, we are happy to do that. But I know some people have the places they need to get and go. So thank you. Dr. Rodzak. Mm-hmm. I think that's really. Mm-hmm. I think that's a great point. We do have that in part of our resources where if you do have a patient that it might be a good option for, we have on this page, where can I get emergency birth control? And so that's one of the things you could kind of circle it, highlight it. Would you like me to give you that prescription today? Here's the options. There's IUD, there's pills. You know, the one step is available over the counter, but I'd be happy to put this in. So if you need it, you can pick it up anytime, maybe more easily or, so I think that's an excellent point. Mm-hmm. Mm-hmm. And it is, while all things data has limitations, but appropriate for use with patients who are breastfeeding. So you will be able to prescribe that to your patients who are breastfeeding. Yeah.
Thank you for this excellent grand rounds. I just want to express appreciation for Dr. Berghahn's point about our duty to provide accurate information to our patients. I feel like as residents, sometimes we hesitate to offer recommendations that are based on evidence because we don't want to feel like we're coercing the patient, especially when they want to make a decision that's different from what we're recommending. But I think it's important to still provide information that is accurate, that's based on the evidence, and to state what our recommendations are whilst acknowledging that the patient ultimately is the decision maker, and expressing our respect for their autonomy.
I think that's also super important. And part of the tenets of reproductive justice, it isn't like, well, whatever you say, I'm just frustrated and I'm going to ignore it then, right? Part of the tenets of reproductive justice is that patients deserve, want, and need accurate information. So I appreciate that you're highlighting that as well. Hey, thanks. I guess if there's any chat stuff, Jamie, that comments. Okay, we'll take a look at those. Thanks for coming today. Happy to field questions, comments, feedback in person, email, you know where to find myself and the whole team. Thanks, guys.